to order. I'm doing a roll call for us.
Sure thing. Director Gallagher?
Present.
Julie Peterson?
Yes.
Jessica Dixon? Mike Russell?
Here.
And Chair Pimentel.
Here. Before we begin, just welcome Mike to your first. Might be your first.
Second.
My first meeting with you. There you go.
Oh, right.
Thank you.
My first meeting. To me. Thank you for being here all. This is our regular monthly December 10th meeting for the Finance Audit Committee. Any changes to our agenda or our items or the order of the items?
Nope.
We have 5 items scheduled for today. Any public comment on matters not on our agenda? Anything other than the 5 items we have scheduled? Any hands raised?
One public member online and no hands raised.
Any comments? Attendees here? Seeing none. Closing public comments, and we're moving into comments from committee members. This is an opportunity for any committee members to provide anything relevant that's not on today's agenda that they might want to share.
Well, I will share something.
Please.
As part of our holiday spirit kind of events that we're doing around the holidays, I'm really pleased to announce that next Wednesday, 17th, my Castro Valley High School Alumni Chorale Group is coming down, and we are singing out here at 11:30 on Wednesday morning. Probably 11:30 to 12:15-ish, 12:30. It's a subgroup. We don't have everybody wasn't able to make it, but we do have a group of people coming to sing. Right now, the plan is, weather permitting, to be kind of right outside the lobby, kind of near the roundabout.
Yeah.
And if it rains, we'll have to go inside. 11:30. So we'd love to have any and everybody come listen.
My goodness. Well, thank you. Thank you for sharing that.
That's great.
Massive appreciation to you and your group for coming here and providing that spirit. Very thoughtful, very kind. Any other updates from community members? We have other fundraisers we're doing? Seeing none, let's move into our agenda. We have 5 items scheduled for today, 1 on consent for our minutes approval for October 28, 2025. Happy to have a motion approving the minutes. Thank you. And I'll note that although I wasn't here, I'm aware of the minutes and can vote on them appropriately.
All right, I'll take roll on that item. Director Gallagher?
Yes.
Julie Peterson?
Yes.
Jessica Dixon? Yes. Mike Russell?
Yes.
And Chair Pimentel.
Yes. Our next item of our regular discussion items is item number 2, Par Valley Healthcare District and Watsonville Community Hospital 2025 Consolidated Audit Engagement.
Well, it's hard to believe we're already here again. I'm sure it's probably harder for Jessica to believe we're already here again. We have reached out to the same audit team that we have used the last few years. That's Jarrell and Nathan from JWT and Associates to do the audit for the 2025 year. We have the audit engagement letter. It's a $32,000 cost to do the audit, and basically to the extent we can get anything started ahead of year end, sometimes some of the narrative type things, internal controls and things, that work has been started, and most of it will come after year end once we close the December books, with the goal of, the aggressive goal would be to have the audit done by the end of March. The kind of secondary choice is by the end of April, so that we meet all of our reporting covenants. And so I would like to recommend that this audit engagement is forwarded to the healthcare district and the hospital to approve the engagement letter and officially bring on the audit team.
I don't have a motion for this item. Doesn't make sense.
Yeah, ask you a question. This is our, would be our third?
We did 23,
fourth audit.
24, 20, this will be, yeah, wait. 22's,
Partial year.
we had a partial year one, yeah, 'cause we, yeah, we did a 22 audit with them, I believe. I know we did 23. Yeah, 22 was a weird year.
Yep.
We just had that 4-month thing,
Yeah.
but, you know, just for full years, we've done 23, 24, and the third full year.
Yeah. Question about, if JWT, this could be a conversation, or back, if they have the ability to switch their auditor in charge at any point in the future, give us a different, generally you like to switch auditors periodically, up to 5 years, up to 7 years. We're fine now, I just wonder, planning forward, do they have the ability to provide a different person in charge 2 years from now, if need be, versus having to consider other alternatives? Does that make sense? Like, is there a way to continue with the firm and have them provide a different partner in charge or lead in charge? It's just a question, I'm just asking a question, I don't need a response today. Any other questions on this item? Action is to review and forward to the board. Other questions? Any public comment on this item?
No hands raised.
None here. Call the vote, or a motion? Do you have a second?
I'll second it.
Second.
Almost, Mike.
Yep, almost, Mike. We'll get you on the next one.
I'll take roll.
All right.
Director Gallagher?
Yes.
Julie Peterson?
Yes.
Jessica Dixon? Yes. Mike Russell?
Yes.
Director Patel?
Yes. Item number 3 is our financial performance for October 2025.
The PowerPoint for the most part is gonna look very similar to what you're used to. I did switch up some pages and some kind of comments on some pages a little bit, so I'm gonna not spend too much time in the front slides, just to get to where, you know, there might be a little bit more room for, discussion. I mean, generally speaking, as we have experienced every month, we, had a net loss. This was on $2.3 million. Again, very, volume driven, which becomes a net revenue shortfall. Some expense, improvement to budget, but not nearly, to the extent of where we lose out on the net revenue. And so we did have probably the one, kind of unusual item in the month of let's say March. The month of October was, in professional fees and medical, and we had some, write-offs from some old accruals that did not, materialize the way we expected them to, and ended up at about a $400,000 adjustment to, and so you see that a little bit higher professional fees, medical this month. Other than that, I think let's take a look at the year-to-date. So, you know, from a year-to-date, standpoint, we're $18 million unfavorable, so $18 million loss, opposed to almost $1.4 million expected favorable budget. As we've talked about all year, it's been a net revenue problem and not being able to keep expenses down. You can see we're $8.5 million favorable to our expense budget, but almost $29 million unfavorable to our net revenue budget. And that is a combination of programs that did not develop as anticipated during the budget, shortfalls in collections, service mix. You know, payer mix has been fairly consistent all year. It's a little bit volatile, and I think, as we'll see in the next slide, you'll see some of the volatility in the last few months. So coming over here, you know, one thing that I did a little bit differently, you know, when you're having a year like we're having is, sometimes trying to drill into where we're seeing some either improvement or not improvement as it relates to, we went one slide too many. Yeah, as it relates to something you can kind of measure on a consistent basis. So we use case mix adjusted discharge here because there is, a bit of a shift in our case mix. We're, slightly higher this year than we were last year, which at times can lead to higher expenses to take care of that population. The other part of this calculation, though, is the adjustment factor, the outpatient adjustment factor, which, helps you to normalize that outpatients typically are not as complex and resource intensive as inpatients are. But what's also unique in this kind of situation is we've seen, our inpatient volume drop off this year. We've seen our outpatient volume increasing. So it's, it's not always just like, oh, well, that was the same book of business and we're just doing better. It's the fact that that complexity and that resource intensity has also changed. And so this adjustment factor helps you kind of normalize for that. And the other piece, the other bullet point that I made here is this idea that the length of stay and resource utilization of higher acuity patients will really drive an inpatient gross charges, expenses, whatnot, where you don't have that same thing on the outpatient side. But again, this adjustment factor and then looking at this adjusted CMI discharge year over year tries to make it look more like you're looking at an apples to apples sort of thing. And so if you look at the kind of bottom section of this slide, you see that from a case mix adjusted discharge, we're collecting $1,700 less. So some of that, again, can be service mix, it can be payer mix, and it can be collectability. From a labor perspective, we're up about 2% year over year. That falls pretty much in line with what you would expect with contractual obligations to the union staff. Pro fees, and we've had a number of professional fee items this year that have increased, both in terms of changing some of our physician groups as well as some of our existing physician groups commanding higher rates from us. So that's where we see, a significant increase of 26%. We have made some major improvements in supplies at this measurement. We always feel like supply opportunity is still there, and we haven't reached it, but this, did kind of remind me that we have reached some of it, just more to go. And you can see, basically in the last few line items that we're actually performing on a year-over-year basis better this year than last year. So I guess in a way, it was a little bit of a bright spot for me to look at the data this way because it's been so hard to, month over month just be looking at negative numbers and wondering, are you doing enough? And while there's certainly the need to do more because we can't sustain at a $18 million a year loss, or probably closer to 20 by the time we're done, it does at least say some of the steps we're taking are making a difference. If you go to the next slide, I just highlighted the two big ones being that the net operating revenue was down 17% and the pro fees was up 26%. I think, when I talked about that shift for the outpatient adjustment factor and the fact that we see less inpatients and more outpatients this year, the reason that has such an impact on net operating revenue is that inpatient reimbursement is stronger than outpatient. And I just did a very high level, kind of estimation that it's, 55 to 60% higher to reimburse an inpatient case than it is an outpatient case. So we might have a lot more outpatient cases, but they're not commanding the same level of reimbursement per case. We've talked that our volumes being down, about 11% on inpatient volumes. And outpatient volume is, it's relatively flat. The non-ED outpatient volume has been growing, a couple percentage points, but the ED volume has had some lower months, and if you look at it kind of on a year-to-date basis, is relatively flat. I spoke about the pro fees, and, so far, $2.5 million more year over year. Okay, let's go on to the.
And I have a bigger than us question about inpatient volumes. I can imagine this is like hospitals like us. What are our peers seeing in inpatient volumes? Are there any? Has anybody solved for that yet? Has anybody determined how it community comfort to come back? Or
Well, I think in every hospital, situation is different as to why you have your inpatient volumes or not. So there's not necessarily like a peer group, a good situation, because, it depends on how many other hospitals are in your area. It depends, with us, some of it may be ICE related and immigration related, and the next closest may or may not have that sort of issue. That's not something that I'm kind of tapped into
that's
in terms of how others are. From a volume perspective, this month, very low admissions. We were 17, very low, meaning compared to budget, 17.5%. 254 is, in the range of where we've been for the rest of the month, or the rest of the months this year, but still a little bit on the lower side. The patient days, because, our length of stay was a little higher this month than it has been. The patient days didn't drop quite as much as that, but they're still, 933 is not a strong month, because that leaves us a census of about 30, and well below where we thought we would be and where we historically in prior years have run, prior is 24. On the deliveries, they were pretty close to budget, a normal strong month at 68. And the surgeries did pretty well for the month of October. We were actually up in inpatient surgeries and outpatient pretty much at budget. But you can see that the non-ED hospital visits were down 500,000. Some of our visits have been down, related to things going on in radiology without MRI. We've gone through construction. We have different times when we have staffing issues and things like that. We've also, tried to tighten some of our schedules in some of the other ancillary areas, not to cut out volume, but just to make sure that we're not staffing for hours that don't really generate revenue and bring in patients. So the year-to-date, really not that much different, and was pretty consistent with what we've been seeing all along, almost down in admissions, and pretty flat on deliveries, decent, up on inpatient surgeries overall, down on outpatient, mostly related to not having any of those cath lab procedures in that we had budgeted for, and the loss of certain physicians that have been recruited to fill those spots, but we've done a number of months in 25 without those physicians. And then, probably most surprising, but again, could be related to ICE and other things, is the 8% down in ER visits, and running still for the size of our ER, 93 patients a day is still a good haul for them, but, down from what we budgeted. Slide, please. So here was just, kind of a look at, our volumes and our patient days, and you can see, patient days generally will follow, the number of admissions, and the length of stay is the driver that sometimes puts them out of whack. So I've listed the length of stay below. But, on a year-to-date basis, I remember correctly, we're sitting at, a length of stay of 3.34 for the year, which is somewhat demonstrates that we don't have necessarily high acute patients and that we manage the length of stay pretty well. Generally, with some exceptions, but generally do pretty good at getting patients placed at the proper post-acute level of care within a reasonable amount of time. Next slide. A quick look at deliveries. It's been pretty consistent all year long. And what I did at the bottom is I actually listed, our NICU admissions, because those have been pretty strong most months. Some months, August was just crazy NICU admission month, but, most of the months running somewhere in the 7 to 10 range. So, kind of where we run. So if you think about it in terms of the total number of deliveries we do, 10% or so, a little less than 10%. Next slide. Here, top graph is just showing you the trend on ER and non-ER outpatient visits, mostly, generally fairly flat, but you can see where the non-ER outpatient visits have been generally trending downward since about the middle of the year. And, as we work towards bringing on the CT and the MRI in the first quarter of next year, that should help bring some of those visits up. I think as we work on, filling, now that we have these, existing surgeon positions filled, and as they start to refer volume and pre-op tests and things, that should also help those numbers. And then the bottom slide relating to the ER visits per day and what percentage of those are converting to inpatients. Over the course of the year, we've seen a little bit of drop off in the percentage that convert to inpatients, and kind of run really generally about the low 6% of our ER visits that convert into an inpatient. Because if you really look at the acuity levels in our emergency room, generally speaking, they're fairly low acuity visits. Next slide. Then I wanted to drill down a little bit into the surgical cases. So rather than trying to show you all of them and make the graphs really hard to read, I just picked kind of the top volume areas for both inpatient and outpatient surgical cases. It's been the same top 3 categories pretty much all year long. And you can see that, like, for this month, we had, OBGYN tends to kind of top the chart. And then the general surgery is usually the second highest, although this month it's like GI, beat it out by 1 case. And then on the outpatient surgery, general surgeries, ortho, OBGYN, podiatry, ENT, top 5, because I wanted anywhere that there was some, fairly significant volume or growing volume, like this was a good month for the outpatient ENT, kind of how they made the list. I think, what's hopeful or exciting to be looking at is, we now have a new orthopedic surgeon, and as she ramps up, Dr. Etchison, as she ramps up, being able to contribute to that ortho case number which will be, good. And then we have a new general surgeon, Dr. Allen, who's coming in January, to replace Dr. Brandt, and that'll be another, opportunity, to, increase some volume, because general surgery does tend to always be our largest outpatient surgical volume. And then at the bottom, just for reference, I put down what the robot-assisted cases were, and, you know, other than the month of September, we've, and February from last year, we've, tended to be pretty consistent with how our robot usage is going. Payer mix, so inpatient, commercial rebounded a bit from a very low September at 12%. So 15% is kind of middle of the pack for us in terms of where we tend to land, usually somewhere between about 14 and 17%. The Alliance fairly strong at almost 45%. Medicare was down a bit at just shy of 27%. And, you know, over the last, I guess, you know, looking here, it's really over the last year, but I think I've felt it or noticed it more over the last 6 months or so that the managed Medicare has picked up a bit, which I find a little bit ironic because there's fewer and fewer managed Medicare plans available in our county. But they, you know, there's people that are aging and need a managed Medicare plan. It just becomes a little bit harder to find them. You know, Aetna recently pulled out of the county, the Aetna Dignity Plan, and I think now we're down to basically Kaiser and the Sutter Health Alignment, you know, any of the other sorts of programs where you can just get a Part D program or a Medigap policy, but the two major kind of catch-all senior advantage programs, I think, go down to those two. On the outpatient side, commercial volume was very consistent with where it's been at 23%. The last 3 months, we've been right in the 23% range. Alliance was down about a percentage, and the pickup there was really kind of split between the managed Medi-Cal, the managed Medicare, and a little bit more to self-pay, and Medicare was pretty consistent the last 3 months. So the outpatient mix really just isn't moving too much. My point of note there was, you know, for the high percentage of government payers that we have, especially in our outpatient mix, that's the significant kind of drag on outpatient reimbursement because they pay significantly less than a commercial payer pays. And that was my last slide, so I can take some questions.
The IP payer mix, how might we see this in total count instead of percent?
You want to know how many actual, like, Alliance payers or patients there were? That could be changed.
I think in addition would be helpful if it.
Would you prefer a second slide or just to try to have, I was gonna say, I don't know if I know how to do two labels.
No.
I don't know if you can, but you could have like same slide with count or something.
Yeah.
Okay. Do you only want that on the inpatient or would you want that on the outpatient?
My real interest is inpatient, but
Okay.
why not?
I don't know it.
in the CMI just discharge slide, if you, my head kind of there is getting that. Talk to me a little bit more about the pro fees medical, how did we arrive at the 785?
So, just from a calculation standpoint, your case mix adjusted discharge, you know, you have your number of discharges, you add on your adjustment factor that normalizes that maybe you have, for every one inpatient, you have 2 outpatients, roughly. I mean, it's probably a little bit more than that. It's probably more like a 3-to-1 ratio. Cause, yeah, it is, because our outpatient adjustment factor is up over 3 now. So it's basically saying, you know, the outpatients, there's 3 outpatients for every 1 inpatient in this calculation. And then you multiply that by your case mix, which, you know, year over year is relatively flat, a little bit higher in this current year. That becomes your denominator. So you take a number like 10, you multiply that by 3, becomes 30, you multiply it by another 1.5, becomes 45. You know, you take your expenses, which are, or your net revenue, which are up in the bucket above it, and you just divide those by that number. And so it's what renders you that says, like for pro fees, this year we've spent $9.8 million, and I probably don't think I have it on here, so I don't know what that denominator number is, but divide that 9.8 million by your denominator, and it's going to say, so that says you're spending $785 for every CMI adjusted discharge that you do. You know, where last year we only spent $7.4 million, we had a different CMI adjusted discharge because we had more inpatients, so that adjustment factor was a little less, maybe it was 2.9 or something like that. And then the case mix was only off, you know, that was the difference between 1.48 and 1.47. But it said, well, last year you were only spending $625 on that. And so, but really what's driving that 625 to 785 is we've got a new radiology group, we've got a new hospitalist group, but we went through this whole period of time, kind of that interim hospitalist period from, you know, January to September, where we had even a more expensive coverage for hospitalists just with kind of to maintain our hospitalist service. We also, those are the 2 big ones. This would include where, you know, that $400,000 write-off that, you know, adds into the cost of this year's. We have also just in like some of our surgery call contracts, those daily rates have increased. I think even this year our, I'm remembering my timing right, the intensivist cost changed and increased. So it's been, you know, a number of different items that have just said costing us more to staff this hospital with physicians.
I'm really appreciating the work to get to this, and I like the setup of how you set this up of wanting to better understand what's really going on. Numbers, so it's really creative. Brain is trying to process like how might I this is speaking approach, so I appreciate what you thought about it.
Thank you. You know, a lot of times it is, you know, it's like, this case is just like no other case,
Yeah.
you know?
Yeah.
And so you look for things that, you know, how do you normalize things?
Yeah.
Just like we'll do things on an expense per unit service basis. But this one where the acuity can change, the mix of inpatient to outpatient can change. This is just kind of a nice way to try to normalize those. This was a very common, the calculation was not, the calculation to get the CMI adjusted discharge was exactly what I described, but, you know, about 10 or 12, maybe 15 years ago, I'm trying to remember when the big Medicare affordability, I think it was about 2009 or so when I was at Sutter, and we had a big initiative around Medicare affordability, and I mean, like, everything you did was tied to this, and we had this very complicated calculation of how you got all the different inputs to somewhat normalize them, but it was really a driving force, because it was that whole thing of like, am I losing 30% on Medicare patients, 20%, you know, and I mean, at that point, like, you know, best practice was like if you only lost 15 or 20% versus 30 or 40%. So it's kind of one that we haven't used around here very much, but when I started thinking about it, like I said, it kind of provided a little bit of a bright spot to otherwise bleak information.
It continues to be, there's a difference between cases of grief and well past denial, right? It continues to
Well, every morning I wake up thinking, gosh, it's going to be good.
Right.
Maybe I'm not that far.
like getting to the root of where our patients are, what are they choosing to do that's changed the behavior, providers that have changed the behavior, like trying to get to the root of, is this a moment or a reset? My day job is trying to understand that as well. Moment or a reset. In my day job, we look across population demographics. There's kind of net migration out. Very shocking cost to live here, but it's not at a level where we're seeing 20% population. Trying to equate that to bigger declines in service demand. I think we're all confounded by trying to get to our unique, what is the driver for us?
Well, you know, human behavior sometimes can say, I'm only going to go to some place for so long looking for something that isn't there before I'm going to, like, kind of redirect. And, you know, you can think about that both from a referring physician, like, I wanted to send you these, but you didn't have the coverage or you didn't have the equipment or you don't offer that service. So ultimately, I just started directing over here, and then you have to, if you ever get to that point where you can do it, you got to work hard to get that business back. Same thing can, you know, happen, and it's probably much more on a patient satisfaction, which luckily we have good patient satisfaction numbers. But certainly, you know, one bad visit, you're gone. You know, you might have 3 good visits and then kind of a mediocre visit, and you're willing to come back. So I think we're better off there. But, you know, it really comes back to the cash problem, which is some of these things where we could potentially do more for the community in terms of services or service offerings, you know, we're cash strapped in. So we are what we are, and until we, you know, become something different from with a strategic partnership, or some other way of finding cash, that's going to continue to be our constraint.
I'm not sure how you do this for me, but I end every one of these presentations. Good, at the level of understanding the data and appreciating continuous improvement, what your team are focused on, and continue trying to solve. As a board member and community member, it's gratifying to see that kind of that fight, that want to still understand it, and thinking of different ways that we're approaching it. I don't want to ignore that, and I appreciate in your team approach. It's a hard time to find that energy to keep
On to the next.
So those were my questions. Any other questions, comments? Online? Not an action item, but
No hands online.
all right, well, let's move on to our next item is item number 4.
And for the budget, Vanessa, who is online, and our Director of Finance and Planning and Analysis, and has been the lead over this budget, her and Dina and others have, done a tremendous amount of work on this budget, a lot of details. They've done a lot of digging, which doesn't always kind of come out in the high-level slides we try to share with you, and some of that is because we try to keep it, high enough level, not to get into the weeds that they have been in for the last 6 months on almost a daily basis. But I'm going to let Vanessa do the honors of presenting this.
Yep. So what I'm showing here is, I think first on the title page, I think I need to change my stock photo for the hospital because I feel like we're using the same one for every presentation. So maybe I'll look for something different. So for the consolidated summary here, what we've shown kind of to Julie's point is to keep it very simple and high level. So the different columns, you'll see kind of what we projected 2025 annualized to be, and kind of it's on par in terms of what Julie kind of showed with the October year to date. 2026 base is kind of what we assume is pre-initiatives, but inclusive of HR1 and IGT. And then the initiatives is basically kind of the items that we've identified that are initiatives for 2026. And then 2026 budget is basically the sum of the base and initiatives. So what we've shown here is kind of showing that our gross patient revenue, we show you the deductions, the provisions for back debts. You'll see here that the dish cloth IGT obviously has increased quite a bit from 25 to 26. So that's again, modeling cloth 9 at the 75% inclusive, as well as the IGT funding. Other revenue is a slight dip. That is due to the reduction in kind of loan forgiveness amounts and other funding sources that will no longer continue in 2026 to get to your net operating revenue. You'll see here overall that our expenses are increasing. Luckily, we get some savings. You see kind of driven by the initiative with supplies to kind of see that where our expense savings are. But for the most part, to Julie's point, is our expenses are increasing, and kind of to belabor what she talked about, our medical specialty fees has increased. We see it in 25, but we also saw kind of, to Julie's point, is an increase in our physician on-call rates that we saw about 20% increase, along with the additional contracts in M-Care, hospitalists, and other provider groups. So the bottom line in terms of the EBITDA, we're at a negative 5 million EBITDA. You'll see here also that we have an increase in depreciation and amortization. So we've kind of isolated that the 368 in initiatives is due to the CT MRI, which I'll get into further detail in another slide. But again, an increase in depreciation and amortization due to the fact that we actually introduced capital items in 25 and into 26.
And I'll just make a quick plug on that, which is, besides the Measure N funding, we've had a very nice grant from the Alliance, so that's allowing us to purchase some well-needed capital that's going to come online at different parts of time in 26. So we've tried to kind of time the depreciation of when those things would be implemented. Plus some of the things that are being done by Measure N, such as the signage and the LED lighting project.
Perfect. So I'll stop there for a moment to see if there's any questions about this kind of high-level summary of our budget at this point before we move on to the next slide, which kind of delves into further of what the 2026 initiatives are and kind of how that was analyzed and put forth in terms of the numbers you see here.
I think, knowing what's coming, you might want to go a couple slides into this where you do show your initiatives and kind of your assumptions page, and then maybe stop. It'll help kind of things sink in a bit.
Okay, so moving on to the next slide. This is our 2026 initiatives. You'll see up top kind of the different ones that we had indicated prior meetings, the CT MRI growth, the 340B, the cath lab, supply savings, and RCM improvements. So the MRI CT volume growth was basically the incremental volume growth due to the new and more efficient equipment. This is the more organic growth in terms of, even though there's increased capacity, this is the projected volumes that they felt comfortable kind of seeing that will come through the door in 2026. So you'll see here, we've identified the revenue, kind of understood what the deductions are to kind of get to an EBITDA per case, along with kind of the relevant expenses. And then you'll see here again, the depreciation and amortization for that new equipment. Moving on to 340B. This is essentially the projected savings, about $10,000 a week in terms of kind of the 340B program that's been in effect this year and kind of what we're hoping for into 2026. The cath lab, and basically this represents kind of minimal staffing and lease expenses to determine best use. There is no volume projections here. It is more of an exploratory type of initiative in terms of how it comes to the cath lab. Moving on to supply savings, this is a projected savings in terms of process optimization and contract utilization. And then with the RCM improvements, had a good chat with Mike to kind of help me understand, he's pursuing opportunities in cash realization and acceleration. So cash realization is really to try to kind of get those dollars that we feel we're not collecting upon. And the acceleration aspect of the improvements and those opportunities to kind of allow us to get cash through the door quicker. So the 1.75 there is to capture kind of what that amount is, but also keep in mind is the time value of money, and hopefully that acceleration allows us to collect cash faster. That's more kind of the qualitative aspects of kind of what he's trying to pursue. So I'll stop there to see if there's any questions or.
Yeah, so that's, I appreciate. Really, thanks for getting here. But I think I'm curious in the credibility is not the right framing, but the confidence factor in each of these assumptions. For example, with CLOP 9, we're using a 75% confidence factor. What level in these assumptions, I want to believe and I would expect we're probably being conservative, but like, what's the level of conservatism that's tied into each of these? Speak to that.
Maybe let me help, and I'll let her weigh in on any other conversations she's had directly with the directors. But with the CT and MRI growth, we are going pretty conservative from two standpoints. One is that the MRI has been down for a few months, and so at some point you will get that volume back, but you may not just start at full forces on day one. So you may have a ramp up period of a little bit of time before you get back to what your normal volume is, and then to that point of physician referral behavior or patient behavior, getting people to realize oh, that's the place to go. They got the new fastest, shiniest, quietest machine. So that MRI growth is kind of a slower ramp up. The CT, again, it's a pretty conservative estimation, and we wanted to be conservative because we still have room in our kind of current CT schedule. We're not fully utilized at this point. What our director has said is there's more volume out there to be had, but it does require, marketing outreach, really kind of pounding the pavement to redirect those referrals here. And so that's kind of the piece that's not reflective here. If you really went full forces at that kind and thought you were going to devote a lot of energy to that, you would be adding some salary costs because you would finally hit that volume point where you needed additional staffing. This is all volume that will be kind of received within existing staffing. So to the point there, it's we're really not adding expense to this piece other than the depreciation and amortization. This is pretty much be all just new revenue. The 340B, we're realizing $10,000 a week now. There's the potential that number can and should improve, but there's just a lot of energy and work that goes into getting this program established, getting all the data points right, making sure you have it's a very regulated program, so making sure you're doing it right. So the 520 is a $10,000 a week conservative approach that we hope by the end of the year we would see kind of growing out of. I'll come to the cath lab last. Supply savings, because there's so much process work to kind of improve how we do PAR levels, how we manage to the Vizient contract, are we in the right tiers? Our new supply chain director, who's been here since August, basically said, I think there's more here, but I'm going to give you the kind of conservative industry benchmark of about 3% of my current supply costs as a placeholder. And he is tracking, and he's working right now on what's been kind of realized to date, and then we'll continue to track what is being realized. On the rev cycle side, Mike has done some extensive analysis, and he's got, 8 to 12 line items of different types of things to look at between, collecting on underpayments, denials and appeal work, some of the cash acceleration, something that he's going also to be talking to you about in our next agenda item with re-looking at some accounts that have already gone to zero, CDI work, clinical documentation improvement work. So he built a high, medium, and low range, and then we kind of picked the middle point of that. The cath lab is probably, I would say probably the biggest surprise in this budget is that we're in a place, as we've evaluated what's happened with our cath lab this year, what has happened with the physician community around the cath lab, that, volume is, how we're going to get that volume and how much we can count on is a challenge, and that's why we pulled the volume out. And really what we said is right now, and we've been staffing, the main RN in this is a registry nurse, and he's been very instrumental in how far we've gotten the cath lab in terms of getting it ready for startup. We still have an application in for PCI, that if it materializes at all will be towards the end of 26. So we left some dollars in to continue to have that sort of a resource, and then we have the lease and rent costs, so that's kind of a sunk cost. Those are the dollars, and nothing else is in here. But there is other exploration going on about what other types of services could we do in our cath lab. If we, if the radiologists recruit interventionalists, we can do interventional radiology. I think there's been conversations about EP procedures, and I'm not sure if they would end up in the procedure room, but we're not giving up. We're basically just saying we're trying to think outside the box. And so this is why this initiative, just looks at some bare bones expenses.
Really helpful. I appreciate that context.
Anything you would want to add, Vanessa, based on your conversations with directors?
No, I think you captured it exactly. Like I said, the CTMR growth, kind of like that organic kind of what can be dealt with now without additional expenses incurred. So spot on in terms of kind of what you just shared with the group.
All right.
And a specific little in the weeds question on the 340B on a silly little podcast, they were talking about the reforms of the program that changes to favor of the pharmaceutical. That, if I recall correctly, it's almost like a more of a reimbursement method.
A rebate or...
Yeah, but we have to apply after the fact of the current model. Is that anything that, how does that impact us, or is that something?
No, it's something everybody's fighting.
Yeah.
Yeah. And I'm out of touch if it's actually shifted. I know there's been,
Yeah.
you're right, that the pharmaceutical companies have been pushing for that, and the hospital associations and others have been saying,
Yep.
that's not fair, don't do that. That is, some of the, representatives and stuff, kind of favor on the hospital side.
Right now, this is modeling the program as we know it.
Yeah, yeah. Because really what that would be is you potentially end up being the same dollars that you probably fight for a little bit more, but it's that delayed cash, and it's like, we need the cash. We need to not be putting the dollars out in the first place to wait around to get them back. The program as it's designed now allows us to go purchase at lower prices.
So I'm good. Sorry, Vanessa, to throw your rhythm off, but you want to keep going?
No, that's fine. I guess we could skip this one because this is basically just breaking out kind of the budget in terms of the different entities. So I think we can skip this and kind of move on to the next one, which is more underlying base assumptions. So like Julie said, there was a lot of detail in terms of kind of what goes into the budget. Oops, one back. But, oops. Sorry, we're on the, yeah, there we go. But we kind of wanted to at least highlight the top ones, kind of major drivers. So we increased our CDM about 2% overall. There's strategic increases and decreases all around. And then there was a market comparison to local competitors completed. So this is the work that we worked, collaborated with Mike to kind of see what our strategy is that way. Wanted to highlight that we had 3 major payer contracts negotiated this year with some favorable increases. So that was a good thing that kind of also fed into our budget. Kind of the same story about how Quaff 9 is about 75% in terms of both receipts and expenses, highlighting the new IGT transfer of a net dollars about $2.4 million. Highlighting again, I think I spoke to it earlier about our other operating revenue kind of taking a decline. It's more or less loan forgiveness, which is driving that amount. Overarching inflationary factors that we looked at was between 3 and 7%. Going back to kind of what Julie alluded to in our medical specialty fees, that even though we already saw a dramatic increase from 24 to 25, there's even further increases that kind of exacerbated kind of our normal trend. And it's closer to about 7% or an amount about $806,000 total. Another thing that was also driving in our expenses was that we saw our health benefits increase at a unit basis of about 14.2%. Which added about $2.1 million to our expenses in 26 versus 25. So I'll stop there. We can, like Julie alluded to, there's a lot of details in terms of kind of what that, but those are kind of the big highlights we wanted to indicate in terms of kind of driving our expenses to go up.
And it scares me when I get to this moment. CDM, I know that term, I can't.
That is our charge. That is our charge master. So we look at kind of our rack rate for the different services that are provided. Mike and his team do a great job to kind of compare and see where we are in terms of what looks like can allow us to be more competitive and also kind of maybe manage to get an increase in our reimbursements. Any other questions? Yep, no problem.
And I'll just, this is not new news, but I think it's important at kind of this stage when it's supposed to talk about like CDM, but even just the overall budget, is that we're doing this in Excel, where most places would do it with tools and corporate departments and everything else, because this is, the meat of that budget, the underlying factors is a gazillion Excel spreadsheets with a lot of detail. They make my head spin.
Yes, we have a multitude of models and ensuring we're capturing everything and understanding the driving factors into this budget. But yes, it's all Excel based.
The county's 50 years older than you. We just switched away from Excel 3 years ago. So I think for time years, you might be ahead of the schedule.
So again, we're just kind of, in this slide, we're just, again, reiterating the volumes, looking at 24, 25, and kind of a budget. Kind of, like we kind of said before, 10% decreases in admissions, 7% decrease in our patient days, decreases in ED visits. On the bright side, we did see project increases in other OP visits, total surgeries, and also an increase in deliveries. And then, these are just kind of some KPIs we wanted to show, similar to what Julie had said, kind of trying to normalize things to look at, what is our gross revenue per adjusted patient day, our net revenue, our percentage of bad debt. And again, you can kind of see our labor expenses are increasing. Our supplies, due to the fact that are increasing, but we do see a reduction based on the supplies initiative. So that's kind of a win. But then you'll also see that all other expenses are increasing. And again, that major driver in all other expenses are quaff fees. So going from our EBITDA margin of negative 5.5 to negative 4.1 is due to the fact of our initiatives. But again, this allows us to kind of see a normalized way of how things are looking like. I wish I had better news, but this is what it is. So next steps is essentially after we review here to get a board approval. We still have more Excel work to do. We then take kind of all the works and the numbers that we've done and kind of do a monthly spread, which is then loaded into MedHost for 2026 reporting, which was a first of what we did for 25. So hopefully from those learnings, it'll be a much simpler process, not easy, but simpler. We'll then update our 2026 reporting package and then get these distributed to both the department level budgets to the respective leaders, along with distributing the summary budgets to our external partners such as HCI, WCCB, and those who we have to provide our 2026 consolidated budget. I think we can probably go back to our consolidated so that we can kind of again, after we've gone through the different assumptions and whatnot, one more, kind of what's driving some of the changes here. So, for example, if you look at our deductions from revenue, that's kind of where one more, sorry. Proceed to the consolidated version. There we go. Again, looking at the way that we accounted for our HR1 impact, you'll see that there's an increase in our deductions for revenue. So that's kind of what's driving that. You'll see that there's a reduction in our bad debt. Again, our DISH, QUAF, IGT was increasing. Again, that's predominantly our QUAF 9 and our IGT. Other revenue I kind of alluded to before, that was less loan recognition or forgiveness amounts. Again, reiterating about our medical specialty fees, where we saw the increase from 24 to 25 and then continue on into 26, where we saw physician all-call rates increase by 20% or so. Property tax insurance, we saw increases there. That's kind of math behind this number in terms of general liability went about 5%. Our cybersecurity went up pretty high by 25% in 26 versus 25. So that's kind of driving that number there. And again, Julie kind of spoke to the increase in depreciation amortization in terms of the capital that we were able to put in service in 25 and into 26, both for through donations along with kind of the CT MRIs as well. So I know that I spoke quickly. Is there any questions or anything that I can go further in detail?
The question is on the inpatient volume, the admitted volume, 10% decrease in volume count for 2026 below the projected. So I have two questions.
Yeah.
The projected 2025, is that like as of data through actuals of September, October, July? What was the actual baseline of?
Yep, we use year-to-date July, but we've been kind of looking at what our trending is through October, and it seems in line in terms of kind of where we are now. So back in July, we tried to read the tea leaves and saw that we saw declines, and we projected further declines.
And to get it to another 10% reduction on top of this year's projected,
yes.
Is that because we believe that's going to happen, or are we modeling to be conservative? That makes sense. And I know it's an art, not a science.
I think it's a little bit of both. We wanted to be conservative because again, we weren't seeing admissions pop back up. We just saw further declines month over month over month. So we felt that we were unfortunately trying to be more realistic that that would continue into 2026.
Put it on the volume slide.
When we present to the board, it would be helpful. I wouldn't recommend adjusting the budget, I'm not comfortable doing that, but if you can have a disclosure of what a 5% reduction might do to total EBITDA in inpatient, just so we sense of scale, or something gives us a sense of scale of, or maybe it's a per capita, like for every percent swing gets X impact on EBITDA, if that makes sense. I'm trying to get a sense of.
It's a more complicated question because it ripples through every line item of that, so I don't know.
Or maybe it's a verbal, just maybe we just acknowledge. Like there's a level of making sure our community and all our stakeholders and staff understand what we're looking at for 20, understanding the assumptions, and understanding a little bit of a measure of thumb of, well, if it's not 10% and 8%, here's what it could be. If it's not 10% and 5%, here's what it could be. If it's 15% down, it's not 10. Here's what, like giving us a measure of thumb, even if it's a high-low range.
I think I would be more comfortable in saying, you know, the message you've heard all year long is the fact that we can't pull expenses down as quickly as we can lose net revenue. So if we gain some of that back, some of those admissions back, maybe we end up at an average daily census of 28 or 29 versus the 27 budgeted. We're going to do that with some additional expenses in terms of supplies or drugs, likely not many in terms of staffing, you know, so we can, any incremental volume can really improve this bottom line much quicker than an additional loss of volume, you know, does. I'd have to think about, like, you know, how to put a number factor on it, but I think it is really that we are teetering on that space of it's hard to shed more expenses at these low volumes, but anytime we can make an improvement, we don't have to add expense. You know, we add a relatively smaller part of the expense structure.
Let me ask that in shift back. I hear you. I was active listening, not husband ears. Is there a way to verbally report out to the board? It would take X to break even next year. It would take going from a 10% to a 3% drop in emissions, or going to a 5% increase in emissions, or whatever the explanation is. Like, what would it take in our assumption?
Yeah.
What are the major changes that?
Go to the slide that has the per adjusted patient day. At the back.
Go back.
Yeah. The KPIs slide. Okay, so because this really what this is telling you is, let's just use high level numbers. You got $5 million worth of for every $5,000 for every net patient revenue per adjusted patient day.
Yeah.
So anytime you can add an adjusted patient day, and if you just use the assumption that let's say we do 1,000 patient days in a month, and our adjustment factor is 3, so that makes it 3,000 adjusted patient days. So if I go from 3,000 adjusted patient days at $5,000 net revenue, and I go to 3,500 adjusted patient days, we could do that kind of a math and say that's, you know, 500 more adjusted patient days times $5,000 is, you know, what is that, $250,000, something like that, you know. So I think at that kind of a level, we could probably say, you know, the expenses per adjusted patient, you can kind of do the same thing with the expenses, but you would kind of drop that out because the expenses can absorb that volume without growing.
Yeah.
And, you know, so think that was probably the easiest, fastest way to get to something about what's it.
Yeah, I'm not
What's it
looking for
worth?
something in,
Yeah.
you know,
I just had to talk through it myself.
Yeah. I'm looking for an explainer of an asterisk, a caveat that we across the board in the public. I appreciate that. I know I'm asking for.
So I know that the end game of this discussion, we can certainly have more discussion and questions, but the end game is to get a recommendation of this group to take this forward next week.
Yep.
For approval as the 2026 budget. So I think it's a good time to kind of assess your comfort level with that, even though none of us are that comfortable with what the numbers tell us.
I'm in the same spot. We may not like where the model is telling us, but I have trust in the model itself, and I think I have a reasonable expectation or reasonable understanding of the assumptions. I appreciate let me 15 minutes already past our end time. So I'm feeling comfortable that this is ready for the board discussion. And I don't mind. I would welcome setting up, opening this item up, comments about it, and then letting you correct me if I misstate anything. Certainly, I'll welcome my board member here to also chime in at the board meeting.
Yeah, I was going to say one other thing to your point. I'm certainly comfortable with the amount of work that's done and the digging that these guys have done. As you think about like our loan with West County Bank and stuff, we have had to stand up to that group every time and say we're missing budget by more than our 20% reporting covenant. Where in a violation they waive the violation. This gives me a little bit more comfort that maybe we don't keep hitting that target next year, and that we actually can kind of recover from it.
Absolutely. So our request is to review and forward to the board. So I think I'd like to see a motion just to acknowledge that we reviewed it and we're ready and prepared to forward it to the board and we support the budget as is. Mike, your opportunity to get on the board.
Second.
All right, I'll take roll on this item. Director Gallagher?
Yes.
Julie Peterson?
Yes.
Jessica Dixon? Mike Russell?
Mike?
Yep. Yes.
Kevin Rossell?
Yes. Last item is a revenue cycle vendor proposal.
All right. Well, Mike, in his next official capacity on this board, actually is going to,
Wait, sorry, Julie, may I really quick, did we take public comment on this budget item?
Thank you. Do you have any members of the public that would like to speak to the budget review and forward?
No hands on.
None, please. Assuming that doesn't change our motion, we're ready to move forward. Thank you.
all right. So anyway, I'd like to just tee this up that, Mike is going to talk to you about one of his revenue cycle initiatives and, a proposal that he would like to make to this group, of some work that we would like to do. And at this point, I will pass it off to Mike.
Sure. So Vanessa did a great job of kind of capturing the high level quantification of the RCM related opportunities and initiatives for 2026. And one of the biggest contributors to that value is centered around underpayments and zero balance work. So I dove into our AR, and the short answer is I've identified a number of opportunities where accounts at currently a zero balance, meaning that payments have come in, there's no denial for them from every high level lens. It looks like these claims have been paid, no denials, and everything is okay, and the contractualizations have occurred, and we've moved on to the next account. What I've discovered, though, is that there's a fair amount of opportunity here where these claims are being processed and are contractually underpaid, meaning that they should be paid at different fee schedules or reimbursement terms are not being adhered to by various payers. And often the way that this has worked, the kind of industry standard is by a zero balance vendor. They're reviewing AR that is, from our perspective, closed and off the books, and looking for opportunities to identify additional net revenue collection opportunities. This area represents the largest area of revenue cycle optimization from a net revenue realization standpoint. And the structure in which these contracts are typically made is contingency-based, meaning that there's no financial risk for a provider organization to take on this type of endeavor, and they essentially just will take a percentage of net revenue that is collected for their efforts. This is something that is absent from Watsonville currently, and in my opinion, would greatly benefit the organization. And the reason that we want to bring it to this group is, one, for just general awareness of where we see the greatest level of opportunity in optimizing our cash realization in our AR. But the other is that because of the extent that I believe there's opportunities for additional cash collection, the vendor expense would be fairly significant. And this is one of those scenarios where we want to pay this vendor a ton of money because that means they're going to be super successful and they're going to have lots of collections. So the more we pay on this, the better is really kind of the answer. There's 3 vendors that we're vetting right now. They all have kind of pros and cons, and I've had experience with all of them except for one firsthand. So I think we have some really good options in this space. And there's pros and cons for various things that Julie and I are weighing as we move forward in this. But we wanted to bring this to this group firstly, and then where we actually may need to bring it to the broader board beyond just the general awareness is if they do experience success beyond even what I'm anticipating, where that vendor expense would exceed the dollar threshold that requires approval. So that's kind of where we're at. Wanted to see if there's any questions on this. This is a component of that $1.75 million in RCM-related opportunities that Vanessa previously talked about in that itemization stratification of kind of where we are as a total.
Let me ask, Mike, thank you. That concludes your presentation. This feels like the right place. I feel comfortable conceptually, and I'm ready to move forward with it. Let me ask you just 2 clarification questions. One, I think it may sound like an ignorant, silly question, but I've seen collection agreements where they extend multiple years, even though the recovery was a one-time thing. Is this model, one-time recovery, 15% of the one time and they're done, or is there any type of tail that continues to collect on the one-time recovery, if that makes sense?
I think I'm understanding the question. So, if there's a 100,000, just for round numbers, $100,000 net underpayment, and the contingency fee that we negotiate is 20%, we would pay a one-time fee of $20,000 on that $100,000 collection.
Yep, with no tail, no out year. So,
nope.
Appreciate it.
No, it's kind of one done. Correct.
Yep, perfect. And I presume these would look at contractual agreements and not self-pay, or would it look at all payments?
These are all going to be related. Where in my sampling that I've gone through and where I've identified the biggest issue with underpayments is in our commercial space.
Great.
So we're not looking at self-pay. This is truly going to be payer-oriented underpayments.
Thank you. Right.
Mike, this also sounds like a really good idea to me. The only problem I had was on the printing, how it went and got to the bottom, made a financial impact that I kept misreading what the approximate sign as a loss, as a negative 700K. So, where you redo this, I approximate.
That'd be a good thing, just in the board,
Write it out.
just where it says the word approximate, yeah,
Yeah, I couldn't figure out how this was
yeah,
gonna
Will
cost us
do.
700,000.
Will do.
yeah.
As this is an action item, any public comments on this matter? More questions from
No hands on mine.
comments? Final questions?
Great. So Julie and I will move forward to getting, vetting out the various vendor options that we have in this space and getting pen to paper on a signature so we can memorialize an MSA with a vendor. This is something that I want to start sooner rather than later. It may be a little bit of a stretch, but I am aiming to have this completed within this month.
I'll move the motion and ask that there's a report back to this, or that's on consent that a copy of the final executed contract, so we're familiar with who it is and the terms of that, be submitted just as a consent item at a future agenda. With that, that's my motion. Staff's recommendation plus provide the contract as a consent item next finance committee meeting.
I'll second that.
I'll take roll on this item. Director Gallagher?
Yes.
Julie Peterson?
Yes.
Jessica Dixon? Yes. Mike Russell?
Yes.
Yes. That concludes today's meeting. I appreciate the extra time, and thank you all. I know how crazy busy this season is.
Yeah.
And I wish you all a wonderful, hopefully there's a couple hours until break.
Next Wednesday, 11:30.
Next Wednesday at 11:30.
Commercial break.
Yeah, thank you for that. Thank you again, Julie.
Thanks all. Bye.
All right, we're adjourned.
All right. Thank you, everyone.
Thank you.
Bye.
Thank you,
Vanessa.
Vanessa.